First of all, I would like to thank the organizers of the conference for giving an opportunity for all of us to present, myself including. This is a very dear to my heart topic. And I would like to give a snapshot of the complexity of cardiovascular patients. In some ways, we can improve as healthcare providers and a community to make a change in patients' lives and improve quality of their care by implementing multidisciplinary heart teams, MDHTs, okay? And I would like to start, sorry, 1 second. So I would like to start by reading a quote that I really thought that it was really speaking to my heart, and it was very close to my heart. This was a quote by Dr. Joseph Ebinger from Cedars-Sinai Medical Center in Los Angeles. So he says that we as physicians have come to think that we need to be able to tackle everything. One thing we need to recognize that medicine is so complicated that if we try to address everything, we may end up achieving nothing. And indeed, it takes a village. So team-based approach engages healthcare professionals across the spectrum, including physicians, pharmacists, PAs, nurses, dietitians, social workers, behavioral health care coordinators, and more to deliver comprehensive, effective care. This collaborative approach improves communication and coordination of care among team members and provides better opportunities to engage patients in their own care, resulting in personalized, timely, and most importantly, empowering and protocol-driven care. One of the primary advantages of multidisciplinary heart team is the enhancement of diagnostics accuracy. Heart failure and hypertension are among some of the common comorbidities existing in our cardiovascular patients. There are also conditions including diabetes, renal dysfunction, chronic obstructive pulmonary disease, and sometimes engaging subspecialties in their patients' care improves patients' conditions and outcomes. For instance, we as cardiologists may be focusing on their cardiac health and function, while the nephrologist is addressing their renal function and helping us with protecting their renal function, as well as pulmonary specialists helping us in their COPD and other pulmonary condition management. This collaborative assessment ensures that all aspects of patients' health are considered and leading to a more precise and comprehensive diagnosis. I think I'm a little behind on my slides. Okay. Perfect. So cardiovascular multidisciplinary health teams have evolved significantly over the past decades. These teams play a central role in treatment of wide range of cardiovascular diseases. In order to meet specific needs of both patients and heart programs, the composition and function of cardiovascular teams have had to adapt over time. These are very routinely used in multidisciplinary heart teams are routinely used in conditions like valvular heart disease, advanced heart failure and cardiac transplant, adult congenital heart disease, coronary artery disease, geriatric cardiology, cardio-obstetrics, and cardio-oncology. This figure basically shows the connection and the close proximity of work with the patient in the center. It depicts the relationship between key entities involved in the care of the same patient with complex cardiovascular disease. So we have typical members of the team that include cardiac surgeons, interventional cardiologists, interventional imaging specialists, advanced practice clinicians like myself, and members of extended teams are primary care physicians, palliative care, geriatric care specialists, heart failure specialists, among some. The errors highlight the relationship and communication that exists between these entities. This cannot be achieved without hospital administrator support for financial support, billing, coding, and infrastructure, space, and other details that are required for patients' care. This chart is a little busy chart. I'm not going to go into detail of it, but what I want to highlight on this chart is that it depicts the multi-step and complex process that involves into creating and developing a multidisciplinary heart team. And it highlights the importance of constant communication between team members for effective process. Okay. So next we're going to talk about high blood pressure. So elevated blood pressure is a major modifiable risk factor for stroke and cardiovascular disease. Yet progress on controlling hypertension and reducing death and disability from stroke and cardiovascular disease has stalled. Hypertension affects nearly half of all adults in the United States, based on ACC/AHA guidelines by definition of systolic blood pressure over 130 on 2 separate occasions, or people taking antihypertensive drugs. Out of half of the population, only 1 in 4 adult has a blood pressure that is well controlled. And many more patients are unaware that they even have a hypertension. With so much online for the health of many individuals, along with clear indications that the standard physician-led office-based approach for blood pressure control lacks real-world effectiveness. So we fail. A fresh approach that involves coordinated effort among various healthcare professionals to provide comprehensive and patient-centered care is well worth considering. Very often, patients are not even aware that the elevated blood pressure has consequences such as stroke, heart attack, and kidney disease. And this is where patient and community education on cardiovascular risk factors such as hypertension, diabetes, lifestyle, smoking, and weight can make a great impact in controlling them and preventing complications. Education is a cornerstone of effective chronic disease management. Multidisciplinary heart team plays a crucial role in educating patients about their condition, treatment options, and lifestyle modifications. Nurses and health educators within the team can provide detailed instructions on medication adherence, dietary changes, and physical activities, which empowers patients with knowledge, fosters better self-management with a vital for conditions like heart disease and heart failure, which require long-term management. Improved patients' understanding and engagement leads to higher compliance with treatment plans and healthier lifestyle choices, ultimately reducing hospital readmissions and improving quality of life. The economic support team-based care. Hypertension in 2021 was a primary or contributing cause of 691,095 deaths in the United States. And the condition is estimated to cost the United States more than 130 billion per year. This is a great number that we can make an impact. So clearly a large number of healthcare dollars and lives can be saved with better blood pressure control. One of the recently published economic evaluations showed both cost effectiveness for team-based care and significant health benefits. Hypertension management that involves 2 or more caregivers, for example, pharmacist and a nurse, improves blood pressure control, over usual care, as it has been shown in several studies and systematic reviews. Collaborative care also appears to be particularly effective in under-resourced settings, serving underrepresented racial and ethnic minority groups who are disproportionately impacted by hypertension. The meta-analysis, which included 121 comparisons from 100 published articles and encompasses data from 55,920 patients, found that multi-level, multi-component strategies were most effective for systolic blood pressure reduction. So now we're going to shift gear and look at heart failure as one of the other commonly used conditions that multidisciplinary heart teams have been effective. Heart failure is one of the leading and most expensive causes of hospitalizations in the United States and worldwide. However, there is limited data on the impact of post-discharge management. Despite advances in pharmacological and device-based therapies, the outcomes of patients with advanced heart failure remain very poor. Due to complexity of the therapies, multidisciplinary team-based care is necessary to deliver effective therapies across the spectrum of heart failure. Multidisciplinary heart failure team care has been shown to improve overall quality of patient care, patient engagement, and medication safety while reducing the duration and frequency of heart failure hospitalizations. Recently published ACC/AHA HFSA heart failure guidelines endorse multidisciplinary care to assist in the transition from inpatient to outpatient setting and to reduce the risk of readmissions. The core members of the MDHT typically include advanced heart failure cardiologists, advanced practice clinicians, pharmacists, nurses, heart failure program coordinators. When rendering treatment plans, the MDHT must incorporate patient preference and health values while striving to reduce healthcare disparities. The US population is rapidly aging. In the year of 2034, it is projected that older adults, 65 plus, are projected to outnumber children, population less than 18 years of age. Aging is often accompanied by changes in physical and cognitive function, frailty, and cognitive function, frailty, sarcopenia, increased risk of falls, multimorbidity, among some. Treatment decisions in older patients require that healthcare professionals, patient, and their families and caregivers come to a clear understanding of patients' baseline status, procedural risks versus benefits, personal preferences, health values, and prognosis, both with and without intervention. For example, in 2020, ACC Expert Consensus Decision Pathway for TAVR calls for routine pre-TAVR assessment of frailty, disability, physical and cognitive function, and procedural comprehensive geriatric evaluations. Sometimes we're in a hurry to recommend a procedure to a patient or a certain treatment to a patient without involving them in the discussion. So it's important for us to keep in mind that patients' opinion and their health values are taken into consideration. In geriatric patients with heart failure, interdisciplinary geriatric care has been associated with improved quality of life and spiritual well-being, reduced anxiety and depression, which we all see so often in our clinical practices. This is a busy slide, but this is just to depict the prevalence of heart failure worldwide. Prevalence is a proportion of a population with a specific disease or condition at a defined time point, and therefore provides a measure of a disease burden on the population. So this is a snapshot of this particular time. It is known to be more prevalent in Central Europe, North Africa, and in Middle East, with lower rates being in Eastern Europe and South Asia. This graph is showing the financial burden on both patients and their insurances and the system. So this goes to show once again that heart failure is a major healthcare problem and is associated with high use of resources and healthcare dollars. Despite significant enhancements in therapies, morbidity and mortality from heart failure remains still very high. Okay. I want to talk about the psychological burden of chronic cardiovascular conditions and how profound they can be. Anxiety, depression, and stress are common amongst patients with heart failure and hypertension. Some centers even offer support groups, for example, in patients with AICDs and CRT therapies, because of the fear of shocks or having experienced shock from a defibrillator. I had a patient who was shocked inappropriately multiple times while he was showering, and unfortunately, he was associating showering with the shocks. So he was scared to take showers, and this patient definitely needed psychological support, which unfortunately in clinical practice, we don't always have the time for it. Multidisciplinary heart teams often include mental health professionals who can provide counseling and support. Addressing the emotional and psychological aspect of cardiac care is essential for holistic treatment. It will reduce ER visits as well, for sure. Mental health support helps patients cope with their challenges in their condition, improve their overall well-being, and can positively influence physical health outcomes by enhancing motivation and adherence to treatment regimens. In a single retrospective cohort study by Neville Tan and Chris Neal at Western Health in Melbourne, Australia, they evaluated 104 consecutive patients over a 6-month period from July to December of 2021. Patients underwent follow-up up to 7 to 10 days post-discharge, with the mean number being closer to the lower end of this range. And the team that followed up on the patient consisted of physician, pharmacist, and allied health professional. Same-day labs, including electrolytes, BNP, and iron studies, were used to guide their therapy. Cohort was predominantly consistent of male patients, 84% of the patients, and elderly with a mean age of 72 plus or minus 12. Most patients, 71% of them, had heart failure with reduced LVEF of less than 50%. All-cause 30-day readmission rates and heart failure-specific readmission rates were 13.4% and 3.8% respectively, which makes it a 33 and 73% reduction compared to historical admission rates of 20% and 14%. So a great improvement. In conclusion, study indicated that multidisciplinary post-discharge clinic is a feasible and effective way to reduce all-cause and heart failure-specific hospital readmissions. The multidisciplinary heart team plays a central role in contemporary care models for a wide range of cardiovascular diseases. The value of the team lies in the ability to transcend the limitations of established care guidelines by providing most up-to-date and informed treatment recommendations for complex patients. The major challenges that we face for the MDHT include increasing number of clinical scenarios. Like I mentioned earlier, cardio-oncology, cardio-obstetrics, geriatric cardiology, among some. They require greater input, lack of widespread subspecialty expertise, time constraints most often, and lack of reimbursement structures. Although MDHT care has become routine in treatments of complex CAD, valvular heart disease, adult congenital heart disease, and the fields of cardio-obstetrics, cardio-oncology, and geriatric cardiology, there remains a lack of experimental data confirming improved patient outcomes. The studies are lacking more information, and I think part of it is, again, because of the wide range of clinical scenarios. In conclusion, the multidisciplinary heart team approach is indispensable in managing complex cardiovascular conditions that I touched on, such as hypertension and heart failure. By bringing together diverse expertise team, comprehensive assessment, personalized treatment plans, enhanced patient education, efficient care coordination, psychological support, and opportunities for research and innovation. As healthcare continues to evolve, the multidisciplinary approach represents a model of excellence in delivering patient-centered care, ultimately improving patient health and well-being in complex cardiac conditions. It is important to keep in mind your specific patient population and the mix and the goals that you're trying to achieve when you are planning to set up a multidisciplinary heart team. Thank you for your time and your attention.